Hello, everyone. Good morning. It would have been my real pleasure to be there in Cairo in person to give this talk because I really enjoy this meeting. But unfortunately, I've been double booked, so I can't make it. And I promise you that next time I will not miss it. So it is virtual this time. I'm Pradeep Bhandari, I'm a gastroenterologist from UK, and I'll share my experience of endoscopic resection in IBD colon. So, the whole subject of neoplasia in IBD is very complex. Today, we are only going to discuss how to resect the lesion rather than all the other aspects of IBD neoplasia. So I won't go into all this. We just focus today on how to resect. Detection and management of IBD neoplasia has been around for a long time, but with time, as you can see, things have changed. Originally, the thought process was this is a field change and we need to take the whole colon out because the endoscopes were very poor quality, resolution was poor, and knowledge of the endoscopist in detecting neoplasia was poor. So it was not safe to resect endoscopically, and I think the best thing in those days was to take the colon out. But as the prevalence of biologics have increased, the prevalence of these neoplasia in IBD has dropped. At the same time, the resolution of endoscopes and technology, the skills, the know-how, and all these abilities of the endoscopists have increased. So now we're talking more and more about organ preservation techniques like ESD. This is back in, I think, 2004-5, when we were using FICE on old-fashioned scopes. The best way was to use indigo carmine, and even then we were not completely sure as to the margins of lesion. Look at the modern endoscope. This is the LED-powered endoscopes where you can see exactly where the margins are, what is inflammatory, what is regenerative, what is neoplasia. Everything can be defined really well. So it gives the confidence to the endoscopist to isolate the lesion and resect it. Again, you can see here on white light, you can hardly see anything. But as soon as you change it to NBI, you can see the lesion, you can accurately mark it, and you can accurately resect it. And that's what makes ESD a curative procedure in these patients. But when you have these high definition scopes, all these technologies like NBI, BLI, iScan, then you start seeing a lot. And when you evaluate these areas, it looks very worrying and it looks like another patch of dysplasia. But all this is a patch of regenerative tissue following inflammation in a colitic bowel. So it is very challenging, the whole subject of recognizing neoplasia and differentiating it from inflammation, differentiating it from regenerative patches is very challenging. Recently, the term for describing neoplasia and IBD has changed. Originally, we used to call them as DAMs and arms and things like that. Then it became lesions with visible margin, without visible margin. But this recent Delphi study coined a new name called colitis-associated neoplasia called CAN. And all they're saying is that if there is a contraindication to endoscopic resection, then go for surgery. Otherwise, resect it endoscopically. And if possible, all the lesions should be resected in an en bloc fashion. So how do we manage? Basically, all benign, visible neoplastic lesion should be resected endoscopically. If you have a suspicion of submucosal invasion, deep invasion, then it should go for surgery, along with those patients where there is a lot of inflammation and that is not settling down despite maximal medical therapy. If you have multifocal dysplasia, which is not visible despite expert review, and if you have lesions with very indistinct margins and you're very concerned, or if patient decides to go for surgery. Otherwise, almost all the lesions can be resected endoscopically. So ESD in IBD colon, there have been few case reports starting with this small series by a combination of our UK and Japanese endoscopists showing that in 32 dysplastic lesions in 23 patients, or probably I think about 23 British and 9 Japanese patients, ESD is feasible. There you can see that end block resection rate was quite good with no perforation. Similarly, another Japanese series showed the same thing, that in a small number of patients, it is feasible with a very good end block but poor R0, although the perforation rate was about 4%. This is the largest ESD series so far, with 121 patients that we collected across 4 centers. And these patients had a range of procedures performed from EMR to ESD to knife-assisted resection, as you can see there. The size in Paris classification varied, and overall there were about 3% perforation rate, but all these perforations, apart from one, was endoscopically managed. The one that was not managed was a delayed perforation, which required surgery. The delayed bleed rate is quite low. The recurrence is surprisingly low despite these being very challenging lesions. And you can see here that majority of the recurrence was in the EMR group. In ESD group, there was hardly any recurrence. And as I said, perforation required surgery in 2 patients who were unable to resect endoscopically, so they required surgery. And another 5 patients actually had cancer on endoscopic resection in the specimen, and they went for surgery. So overall, the conclusion was that if the lesion is less than 15 millimeter polypoid without fibrosis, they can be resected in an end block fashion by EMR. If they are more than 15 millimeter, or they have fibrosis, or if you're worried, or they are very flat and subtle, then ESD is the technique of choice. So what are the challenges related to endoscopic resection? There are a lot of challenges. First is to detect. Second is to delineate the margins. Next is the severe fibrosis and scarring which is seen. There's sometimes can be a lot of inflammation around the lesion. There's always submucosal fibrosis in these patients. One of the most annoying challenges, there's excessive fat deposition in the submucosal tissue, and that fat causes a lot of challenge, difficult to cut, it melts, it sticks on your lens, and there are always hidden vessels which begin to bleed. So there are a lot of challenges when it comes to resecting lesions in IBD colon. You see here, this is way back, maybe 2005-06, where we had these old generation endoscopes. We used to use indigo-carmine to identify and perform the conventional ESD technique. You can see here, using a combination of dual knife and IT nano, and typically you get underneath it, and then you swipe your knife with as much cushion of tissue as you can have underneath with the injection, and a combination of IT and IT nano and dual work really well. The lesion's almost off. That's the final cut, and there you go. So it was not too bad. Now you can see that with the modern generation endoscope, it's completely different game. We see the lesions, very subtle lesion, but you can see it very well. You can use all the technologies to delineate the margins really well. And that gives a lot of confidence to the endoscopist in terms of identifying, delineating the margins, and trying to achieve an R0 resection for these patients. So the modern generation endoscope has made a huge difference to the outcome of endoscopic resection. Using LCI, BLI, or NBI, we can really delineate margin, mark it really well. Here you see that. So the battlefield has been drawn now, and now the hard part starts. Look at the injection. It's very scarred, fibrotic. The lift is not good at all. It's coming all backwards. There's very little forward lift. So we keep trying till you get some lift, and then you keep at least about 5 to 8 millimeter distance, I would say almost a centimeter from the lesion, and start opening up the mucosa. You see, we go very, very slow, bit by bit, opening the mucosa to basically create a space in which you can start the trimming. Uh, you start trimming and you make more and more space to get underneath these lesions. You see how difficult the lift is and how narrow the space is. So no matter how hard we try, it's very difficult to make a pocket or tunnel in these lesions. Now you have fibrosis as well as fat, and you see the vessels, they start bleeding. Sometimes going underwater makes it very easy to identify the bleeding point. So you just have to use a combination of various tricks to make resection safe in IBD colon. You can see the fibrosis. The modern endoscopes makes it very easy to put your muscle on the right, the lesion on the left. You don't have to always follow the convention of having everything at 6 o'clock and muscle at the bottom. You can retroflex, do it from behind, so it's almost isolated from all the sides. It's shrunk right in the middle, and if whenever we can retroflex, it's much easier to dissect in retroflexion. It gives an added bit of traction to it, but you can see how the lesion is on the right and the muscle is on the left. There's hardly any plane. It's very fibrotic. So we work in very narrow planes, so you have to be really careful, go very, very slow, and sometimes you'll get this kind of bleeding and oozing straight from the muscle. Be very careful in controlling that. This is old, but nowadays we would use Purostat to control, but in those days we were using diathermy. But ultimately, you can see everything's resected. There's still a lot of fat and fibrosis in the base, which is what makes this very, very challenging. But we are very, very confident this is R0 excision with no adverse consequences to the patient. As we talked about the fat, you will see in this lesion that we managed to get a good lift, but as we get underneath it, this is again a very old case back from 2017. You see a lot of fat, and there again, I find sometimes using a combination of IT nano and dual can be very, very useful in achieving a successful resection. Look at the amount of fat there. It's just incredible. This is an interesting case. The lesion is very subtle. It took us a long time to identify and delineate the margins of this lesion. And then you can see the lift is very, very poor. And once you get underneath it, there's so much fat. And this fat is now melting and sticking on the lens, so it becomes very difficult. So now we're using water traction. So we flooded this area with water, and we gently keep flushing water. Look, there's hardly any plane. It's so close to the muscle or to the lesion. So we're using continuous water propulsion to create the traction and resect the lesion. So this is another trick you can use to deal with the fat and the very thin plane to resect these lesions safely. This is a very interesting case, a patient who had some sort of colonic surgery for diverticular disease many years ago, then develops colitis, and then develops a neoplastic lesion right at the anastomotic margin of the previous surgery. This lesion is also very unique. You will see that it is like multiple satellite lesions, like a bunch of grapes scattered all over the place. Uh, it's very unique. And this is again a unique feature of colitis. You only see this in colitic bowel. You don't see in non-colitic bowel lesions like this. So again, it takes a long time to identify and understand, mark these lesions and resect. I'm not going to bore you by showing the resection, but we did manage to successfully resect it by ESD. So in conclusion, identification of dysplasia in IBD can be extremely challenging, and that requires a very good bowel prep, your best endoscope, your best endoscopist, and advanced imaging techniques. Once you have that, then you need your best endoscopist to resect it, and I still believe that resection in IBD colon should be restricted only to expert centers where a lot of this work can be done and handled very carefully, because the consequences of complication in these patients can be terrible. So be very careful. Thank you very much.